Good evening, friends. Today it will be concluding part, hopefully, on the topic evidence-based critical evaluation of techniques of Caesarean section. Let's straightway jump into the topic without wasting any time. Yesterday, I was talking about whether to close single layer or double layer, and I told you the evidence is in favor of double layer if it is primary gravida and single layer if you are concurrently doing the sterilization. What about the suture material and techniques? That is, whether to use a particular type of suture material or whether to do continuous suturing or interrupted suturing. No specific type of suture material was clearly superior in terms of maternal outcome. Usually you use the braided suture material. No information available to recommend the optimal suture material or technique, that is continuous locked or unlocked or interrupted for the uterine incision. But as I was explaining yesterday, it is better not to lock every suture and cause avascularity. Only if there is an active bleeder, then you may lock it. And this evidence is the recent evidence. Choice often resting with the preference of the operator. We usually use Vicryl for the suturing. Finally, I come to the close of the abdominal wall in layers. What are the techniques, different things there? First, let me talk about unnecessary procedures. Abdominal irrigation. Usually after gynec surgeries, people do a saline wash. I mean, even in laparoscopic surgeries, we have seen this. And that would sometimes help in locating the bleeder, if at all anything. They soak, in fact, the whole pelvis with a lot of saline and all the bleeders can be seen easily. But should we do it at Caesarean section? It is unnecessary. Intra-abdominal irrigation did not reduce maternal infectious morbidity beyond the reduction achieved with prophylactic intravenous antibiotics alone. So it's not necessary. Substantially increased the frequency of intraoperative nausea and vomiting and postoperative nausea as well as. So if you irrigate, you're only asking for more trouble. What about visceral peritoneum? Should we close this or not? Again, some people are in a great hurry, so they say no need to close the peritoneum and they leave it alone. But closure helps in prevention of adhesions between uterus, which is raw, wound there, and the intestines and abdominal wall. So that's why if you at least close this parietal peritoneum, that is the UV fold which we incised, adhesion with the raw wound will be prevented. What are the advantages of closure and non-closure? Let's see. As I said, closure will increase the operative time, non-closure will decrease the operative time. Closure will increase the operative morbidity because when you close, you use a lot of suture materials, there will be always inflammation. That's why there will be more postoperative morbidity. More postoperative analgesia is required. Whenever you suture, especially if you suture it very tight, then there will be requirement of analgesia. All these things will obviously prolong the hospital stay postoperatively. Let's see what does the evidence say about closure versus non-closure of the parietal peritoneum or peritoneum in general. Improved short-term postoperative outcome if peritoneum was not closed, but no evidence for non-closure regarding the long-term outcomes. So this is saying short-term, there are some benefits. That is, the surgery can be quicker, post-operative pain and hospital stay will be lesser, but long-term, we don't know. Non-closure was associated with greater adhesions, as I just mentioned in the previous slides. There will be adhesions if you don't close. Peritoneum, after all, is somewhat like a non-adhesive material for the uterus. Again, now I come to unnecessary procedure, adhesion barriers. People have the habit of putting adhesion barrier because this company people will come and promote these things and you feel like putting it, especially the excuse is those who can afford, let me use this. Adhesion rates as it is are not very fixed. It depends upon the person's nature, 11 to 70%. It's not because you create the adhesions. Of course, if you leave behind a lot of blood clots and other things, raw areas, adhesions can happen. Otherwise, usually it depends upon the patient's nature. Bowel obstruction is much lower, 0.5 to 9 per thousand, with highest risk in those who have undergone multiple cesarean births. So that's why adhesion barriers are not always required. Surgicel and other things what we use in gynec surgeries are not required for cesarean deliveries. Evidence does not support the routine use of adhesion barriers in patients undergoing cesarean birth. There is a lot of evidence, 2, 3, 4, 5, 6, all are saying that it is not required. And as you can see, one of them is the latest, 2022, October 7. What about fascia? Surgeons are very particular about how you close the fascia. Whether peritoneum you close or not is not an issue at all. Fascia means rectus sheath actually. So they are very particular because in fact, the strength of the wound depends upon this. The method of facial closure is critical aspect of incisional closure as the facial closure provides most of the abdominal wound strength during healing. Care should be taken to avoid placing too much tension. So some people have the habit of making it too tight and keep on shouting at the assistants to hold it tight and make it very, very tight. So it's not required. Since reapproximation, not strangulation is the goal. We have to, as I said yesterday also, we have to just approximate the tissues and the healing happens naturally. If you think that because of my tight suturing, I'm approximating them, you are actually doing a wrong thing. That will cause avascularity and it will break down. So you have to nicely approximate the tissues, skin and everything. Difficulty with hemostasis is usually not a major issue. Rectus sheath level, usually there won't be any bleeder as such, so you don't have to put any locking and tight sutures. What is the evidence about this, about the closure of fascia? Optimal approach involves use of a continuous, non-interrupted technique. That's what we always do. Slowly and not rapidly absorbable suture. Mass, not layered closure. And suture length to wound length ratio should be 4:1. So obviously suture will be a little longer so that you use more bites. And what is the distance between the bites? Classically, sutures have been placed approximately 1 centimeter from the edge. You take a good chunk of the, otherwise it will tear off of the incision, and 1 centimeter apart. That is approximate distance from one to another without excessive tension. You have to just bring them together. What about reapproximation of rectus muscles? Some people have this habit of putting the rectus muscle so that they think that the intestines won't come up and hamper us at the time of closure. Rectus muscle approximate naturally. We don't have to actually do that. Suturing them together may cause unnecessary pain when the patient starts moving, because when you get up also there is tension on the rectus muscles, and if you have sutured them, that much more pain will be there. You just leave it alone, they will come closer anyway. A reduction in dense adhesions formation when the rectus muscles were approximated. So this is the argument of people who believe in approximating the rectus with 1 or 2 just interrupted sutures. Again, unnecessary procedures. Wound irrigation. I had a teacher who always believed, because for a period of time, there were lots of wound infections in the department when I was a PG. And this particular teacher, always after closing the rectus, she would pour a whole lot of, aseptic solution and wound irrigation she used to do. Irrigation before closure of the subcutaneous tissue did not reduce the rate of surgical set infection and is unnecessary after intravenous antibiotic prophylaxis. Of course, after the procedure the teacher used to do, the infection rate coincidentally came down, and she always claimed that that is her procedure. She found it out. But I never did it subsequently in my faculty period, and the results were no different. So that's why it is unnecessary procedure. Efficacy of irrigation to remove endometrial cells. This is another argument. That is not the infection. Here the argument is that if there are any endometrial cells you have inadvertently put in the subcutaneous tissue, that will cause the scar endometriosis. But as such, the endometriosis in the scar is very, very low, 0.03 to 0.45%. And this has not been extensively studied, so it is considered unnecessary. What about wound drainage? One of my assistants, I don't mind telling the name, Dr. Jairam, because he always believed in putting a drainage, and I always said, please don't put a drainage. We used to always have arguments. What does the evidence say? No evidence to suggest that routine use of wound drains confers any benefit on the women involved. The argument he used to have is that if there is some bleeder or something like that, it will come out. My argument was that if there is any bleeder, you have no business to close the abdomen. Before you close the abdomen, you have to make sure that every bleeder has been secured, either by cautery or by suture or whatever it is. So you cannot leave. Yes, I do agree in gynec surgeries or cancer surgeries, sometimes the surface oozing will be there and you cannot really pinpoint the bleeder and you cannot cauterize or suture en masse. In that particular situation, maybe I agree that a drain has to be kept. But in cesarean section, routine drainage is unnecessary and it will cost, and it will also, you have to remove the drainage and whole lot of things. Trials do not answer the question of whether wound drainage is of benefit when hemostasis is not felt to be adequate. Again, as I say, you should not leave it just a bleeder to bleed there. Hemostasis has to be secure before you close the abdomen. One more slide on this. Routine use of wound drains was not beneficial. Again, Cochrane database, revised Cochrane database in 2013. Routine use of drains does not reduce the odds of seroma, hematoma, infection, and wound disruption. So it doesn't mean anything. It just gives you some psychological, relief that I have put a drain, and if there's anything, it will come out, and it will not collect and become a hematoma. Restricted use of subrectus sheath drains offer no benefit in maternal infectious morbidity compared with liberal use. These findings also apply to patients with obesity. This was another argument. Many people nowadays feel that if it's a very fat abdomen, you just leave a drain at the fat level, or some people even just put a nylon sort of a thread that everything will come out. All these things are not necessary. Our body has such fantastic mechanism. If after ectopic pregnancy, you don't have to, we cannot actually, in fact, clean the peritoneal cavity so dry. And there will be a lot of blood clot here and there. And body has a mechanism to authorize and absorb everything and make it everything clean. So all these unnecessary things to be avoided. Now I come to skin closure. You may be wondering, 3 days and he is not yet finishing the different techniques of cesarean. In fact, I don't know whether I'll be able to finish today. I may have to go on for tomorrow also. There are lots and lots of things about cesarean because this is the commonest surgery that is done all over the world, especially obstetricians. This is the bread and butter. There are so many techniques. So what about skin closure? Skin layer can be closed with non-removable subcuticular stitch. This is the most favorite option nowadays. This is my favorite too. And removable interrupted sutures. In fact, it is done only if you think that it's a very thick abdomen and subcuticular stitches may not hold, then you put interrupted sutures. Skin staplers. This is the favorite of the surgeons, orthopedicians, and all that. And obstetricians should not, they do not want to be lagged behind. And adhesive tapes, especially in laparoscopic surgeries nowadays, we don't even put stitch, we just put adhesive tapes. That can also be done for cesarean wounds. Tissue adhesives, that is a new thing, and it's very expensive. And again, the company representatives come and promote this, saying that if you find a rich patient, you use this, it is so good, and all those things. Let's see what does evidence say about it, about the closure versus non-closure of the subcutaneous fat. Some people say, don't worry about the fat, that will come together, just put about the subcutaneous tissue only. Closure of the subcutaneous fat may reduce wound complications, but it is unclear to what extent these differences affect the well-being and satisfaction of the women concerned. Also, what we can say, if it is very thick, that is more than 2 centimeters, probably it decreases the risk of subsequent wound disruption by 1/3 in patients with subcutaneous tissue depth more than 2 centimeters. But if it is less than 2 centimeters fat, there is no need to put any sutures. That's what it means. Closure of the dead space seems to inhibit accumulation of serum and blood, which can lead to a wound seroma or hematoma and subsequent wound breakdown. So whenever people do something, they want to justify that. So that's what they say. If it is very thick, it is better to put a just approximate and put a stitch instead of leaving it dead space there for collection of serum or the blood. What about the subcuticular versus staples? As I said, we prefer subcuticular. Staples are not bad at all. Staples make the life easy. It is tuck, 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 tuck. You keep on doing. Operating time was significantly shorter. Otherwise, subcuticular, you have to do it very meticulously, especially in obstetrics. Most of them are girls. They would put a beautiful subcuticular stitch. I always left it to either the lady PGs or to junior staff. They would do it very meticulously. They have all the time on earth. And they would do it beautifully. Whereas surgeons and orthopedicians, they have less time, less patience. Maybe they'll put all staples. And we also have picked up the habit. Subcuticular sutures resulted in less post-operative pain and yielded a better cosmetic result. The removal of staples somehow looks ghastly, that remover, though it's not really difficult, but it looks, whereas subcuticular, there is no suture removal at all. So there is no more pain for the patients also. And it is a beautiful scar. You should believe sometimes you have to search where the scar is. And because it is in line with the skin crease. No conclusive evidence about how the skin should be closed. This is the standard dialogue in most of the systematic reviews you will see. What about suture material for skin? Barbed suture reduces the closure time and may result in a better cosmetic appearance, but data are limited and not from trials of Caesarean birth. These are all from the surgery trials, surgical other department trials, not from Caesarean trials. What about tissue adhesives? Yes, surgeons may consider the use of tissue adhesives as an alternative to sutures. So here they have played it very safe. May consider is a very good terminology you will see in most of the conclusions. And or adhesive tapes for closure of incisions in the operative. So they are also welcome. Closing the abdominal wall in general, what does the evidence say? Not enough evidence to say whether particular technique for closing the abdominal wall during cesarean section are better than others. So you can adopt any of the methods that I have already explained, or the method which you have been very comfortable with. You can also use the modern technology of staples, adhesives, and adhesive tapes. What about dressing? There is some controversy in dressing also, but this is better than that. And 2021 article says that advanced dressings, that is hydrogel, hydrocolloids, lignate, film, soft polymer, there are so many of them, do not prevent more surgical site infections than simple dressing, that is basic wound contact or gauze dressing. So fancy dressings. But when I was a SHO in St. John's, before dressing, I used that Neosporin ointment. That is the first research job I did, because of which I got the SHO post in St. John's. So I want to always talk about that whenever I give a talk. That is my first publication as well. So it is always better to use some sort of a local antiseptic. But my professor, another professor, used to say nothing should be used locally whenever you have used IV antibiotics. I think both are okay. Now I come to other issues. We have dealt with all the different techniques of the cesarean section, starting from how to open, how to deliver the placenta, how to close the uterus, peritoneum, abdominal wall, suture materials, techniques, everything we have done with now. So I go to entirely other issues other than the cesarean techniques per se. What about early versus delayed oral fluid post-operatively? Nowadays, it is always fast track. No evidence from the limited randomized trials reviewed to justify policy of withholding oral fluids after uncomplicated cesarean section. Nowadays, in fact, they say earlier you start oral fluids, the earlier the bowels start moving. In olden days, we used to say, unless the bowel moved, don't start anything. But now the entire thing is other way around. If the patient starts drinking, swallowing, then only the bowels start moving. In fact, they have started giving gums to the patients. So when the patients chew the gums, and they'll swallow their own saliva, and that will make the bowel move. So early fluids are always welcome unless patient is feeling nauseated, especially when general anesthesia is used. In spinal anesthesia, earlier we give the oral fluid, better for the patient. What about thromboprophylaxis? When I was in Malaysia, that's the first time I saw them use the thromboprophylaxis, and I was shocked because we always felt that after cesarean delivery, the bleeding, especially after the delivery, postpartum hemorrhage will increase if you used thromboprophylaxis. But thromboprophylaxis, the entire idea and the philosophy is different. When the patients postoperatively are lying down all the time, there is a good chance of DVT, and it is always more hypercoagulable stage in pregnancy, makes the coagulation, more common, and that can cause all sorts of problems. So it is now a practice to use thromboprophylaxis everywhere. Let's see what does the evidence say. There is insufficient evidence on which to base recommendations for thromboprophylaxis during pregnancy and early postnatal period. That was the old review. But now most of us believe that thromboprophylaxis is definitely recommended, and we do give in Manipal, especially those who received it for APRA syndrome throughout the pregnancy. We just stop for a short window of 6 to 12 hours just before the delivery to prevent the postpartum hemorrhage, but promptly we should restart after 6 to 8 hours after the delivery. Past history of DVT. If the patient had a history of deep vein thrombosis, definitely thromboprophylaxis is a must in that patient. Prolonged bed rest during pregnancy, for whatever reason, maybe placenta previa or even preeclampsia, you gave prolonged bed rest. Those patients are likely to develop clots in the postnatal or postoperative period. Prolonged surgery, any surgery more than 30 minutes should actually ideally get thromboprophylaxis, and I'm sure any surgery would go 30 minutes and more. Only cesarean section in expert hands can be shorter, that too when you're very young and enthusiastic, like I did, within 15 minutes. But otherwise, the surgery, normal cesarean also would go to 30 minutes. Obese patients, yes, this is a standard protocol. Conditions predisposing DVT, that is anemia and SLE, and all these patients definitely should receive thromboprophylaxis. And finally, elderly patients. What does evidence say about prophylactic antibiotics? I think I need not talk about the don't need for any evidence. It is very, very obvious and very clear that we cannot withhold prophylactic antibiotics, especially in our setup. So we have to give, even though we clean the abdomen, we clean everything, and we use all surgical techniques. But prophylactic antibiotics is a must. It is usually given just before the incision. So prophylactic antibiotics substantially reduce the incidence of episodes of fever, endometritis, and wound, urinary tract, and other serious infections. So it is definitely to be given. And for a change, Cochrane has given very clear conclusion that it substantially reduces the infection. So you have to use prophylactic antibiotics. So when you say antibiotics, again, the next question will be which antibiotics should be given. And it has also been reviewed nicely. And the evidence says that both ampicillin, amoxicillin, and first generation cephalosporins have similar efficacy in reducing the postoperative endometritis. We used to routinely use ampicillin or amoxicillin in the past. Then we changed over to first generation cephalosporin, and now the standard in Manipal is the second or third generation cephalosporin. No added benefit in utilizing a more broad spectrum agent or a multiple dose regime. Usually they say one dose should be good enough, but we in India, we always use at least 3 to 5 days. In fact, the medicine people make fun of us, saying that OBG people do not know when to stop the antibiotics, because some people used to give 7 days and things like that. Maybe one dose is good enough, but looking at the situation, you can continue for 3 days or even 5 days. The point is that the initial dose should be very high. What about anesthesia? Totally different from obstetrics. Yes, whether regional or general anesthesia, evidence says that not enough evidence to show that either regional or general anesthesia is superior to the other in terms of major and maternal and neonatal outcomes. But we all know that we prefer regional anesthesia. It could be spinal or epidural. Very, very rarely in an emergency or sometimes in a very difficult situation, you may go for general anesthesia. Otherwise, usually it is regional anesthesia. What about spinal or epidural? When you say regional, there are again two choices, spinal and epidural. Again, we have to fall back on the evidence. Evidence says both spinal and epidural techniques provide effective anesthesia. Spinal has shorter onset of time, but need of treatment for hypertension is more likely. So again, even in epidural, if they miss the place, there can be sudden hypertension, and that's why they always give pre-hydration before giving spinal anesthesia. And even pre-oxygenation has become a routine practice now by anesthetists. So, not bad. Today, I can conclude my lecture. I don't have to go for part 4. I will now summarize all the evidence, in fact, about the major steps and techniques, not every aspect what I discussed over last 3 days almost. And I have to give you my takes. I have time and whenever I spoke about a particular thing, I told you what was my choice, but now at the summary level also, I must say, so on the left side, you will say some of the evidence. On the right side, you will see what is my take on that. I have put my picture also there. So first thing about the opening of the abdomen, evidence is in favor of Joel-Cohen or Miscao-Ladakh technique. It has got advantages. It is quick, it is free, it's bloodless almost, and it will not create most of the post-operative problems. What is my take? I would rather say I'm happy with fan and steel. I've never done Joel-Cohen technique or Miscao-Ladakh technique, but in fan and steel also, I avoid much of sharp dissections except for the skin incision and rectus incision, and then you can go just keep on tearing with the finger dissection. That is easier, so it can be faster and less time consuming. What about uterine opening? Again, the evidence is in favor of lower transverse. Obviously, with or without evidence, everybody wants to lower transverse only. So my choice is lower transverse only, unless I am dealing with the case of difficult situation, upper segment only if lower segment is not accessible, approachable, or I'm doing a Caesarean hysterectomy. CH means Caesarean hysterectomy. What about the entry? Evidence says blunt entry is always better, but you can use sharp entry also depending upon the situation. As far as I am concerned, I prefer blunt entry. Sharp, I reserve for a scarred uterus or for a better axis where I want a wider axis to deliver a bigger baby. I know beforehand that I'm dealing with a big baby, or I'm dealing with the twins, or I'm dealing with maybe a transverse lie or internal proteolic version. A lot of manipulation is required. In such a situation, I will go for a sharp dissection. How about delivering the baby? It depends upon the situation. Evidence doesn't talk much about it. So I also will say the same thing. I use the technique depending upon the situation. For a floating head, I may use a simple technique of draining the fluid and pushing from above, or if that doesn't work, I may use a vacuum first and then finally the forceps. For a deeply engaged head, vectase or go below and try to break the vacuum, or if it doesn't deliver, but what is technique. For breech, assisted breech delivery, same as in vaginal, whereas in transverse lie, it's a internal proteolic version followed by breech extraction, and that's how it depends upon the situation. What about placental delivery? Controlled cord traction is the best method, and of course, my take cannot be different. I also prefer controlled cord traction. And then, of course, unnecessary putting hand inside and trying to remove the placenta should be avoided. And as far as the draining or cleaning of the intrauterine cavity, I don't believe in that. I don't do that. As far as opening the cervical os from above, I don't do that. I don't believe in that. What about the uterine closure? No significant differences between intra and extraperitoneal repair. Having said that, I don't want to bring the uterus out all the time. I prefer intraperitoneal repair itself. Just push the uterus by fundus and you get the good exposure of the lower segment and you can suture. Very, very rarely you may exteriorize the uterus and you can do the suturing. Not enough evidence to suggest whether single or double layer closure is better. Having said that, I always prefer double layer closure, especially in primary gravida. Only in multi or repeat cesarean section where I'm doing concurrently tubal ligation, I may go for single layer, which can be faster. Again, continuous suture is always better. Continuous unlocking. There is no need to lock all the time. If you lock, you can unnecessarily cause avascular areas. Having said that, if there is a bleeder, you can always lock. What about abdominal wall closure? Closure of subcutaneous tissue reduces the wound hematoma and seroma. So we always close the subcutaneous tissue. In selected patients, we may also, close the fat layer and things like that. No difference in outcome when drainage is used routinely. I have already told you, I do not prefer to use drain routinely. I don't use it at all. Then comes abdominal wall closure. May use subcuticular sutures or interrupted sutures or staples or tissue adhesives depending upon the preference. And my preference is subcuticular stitch. It looks so beautiful, but I don't do it. I leave it to a very good hand, that is to the good PGs. And finally, other aspects, no evidence on major complications of any type of anesthesia. I leave the anesthesia choice to the anesthetists themselves. As far as antibiotics, we go for cephalosporin group. Usually now we have gone up to 3rd generation because everywhere they are giving the same thing. And if you give lesser than that, it may not act sometimes. But having said that, we have to use the antibiotics very, very judiciously. So I now come to finally holding, no evidence to justify holding back the oral fluids. We don't hold back the oral fluids. In fact, we give it early and we are following the fast track postoperative management that includes not only early fluids, early ambulation, and we just make the patient discharge on 2nd or 3rd day sometimes, because once you remove the dressing and if everything is fine, if the patient is close by, you can discharge them home also. No evidence for postoperative thromboprophylaxis as far as evidence is concerned, but we do believe in giving prophylactic thromboprophylaxis because it will definitely be worth using, because if you don't use, there can be certain problems on 3rd or 4th postoperative day. Even after giving, the patients may succumb to that, but if you don't give, it can be against you. So it is always better to give thromboprophylaxis, and we have been doing it for quite some time now, So I finally conclude this talk on this different technique of cesarean section. I hope I have explained so well that you can do a cesarean section on this tiger as well. Thank you very much. See you after the ACOG Kolkata conference. I'm going to give this talk, but not so much in detail because I nearly took 3 hours to talk about this. The time given to me is 15 minutes. I'll be talking on excerpts only. Thank you very much. See you on Monday.